Hello everyone, this is Matthew Ravi and I'm back here with another topic. And this topic is mid-palmar space, or in other words, acute infections of the hand. So let's get started. So these are the types of infections of the hand. So the first one is paronychia, second one is phelon, the third one is herpetic whitlow, the fourth one is tendon sheath infection, and the fifth one is the deep facial space infection. So altogether five types of infection that I'll be explaining. So the first one is paronychia. So as you can see here is due to the infection under the nail fold, and it is the commonest hand infection. And basically it is seen in children or older people after a rough nail trimming. And as you can see in this picture, the edge of the nail fold is red and tender as well as it is swollen. Okay, so this is the infection here around the nail fold, and also it forms tiny abscess in the nail. So these are the features of paronychia. And for the treatment of this condition is that antibiotics can be given, and if it's given alone also it can be effective. So like cephalosporin, that those kind of antibiotics are given. But if pus is present, it must be released by an incision at the corner of the nail fold in line with the edge of the nail. And paraffin gauze also can be used as a dressing, and that is to keep the nail fold open. But if the pus has spread under the nails or part or all of the nails, then it may need to be removed. So that you should keep it in mind. Now, paronychia also can come in chronic form, which is chronic paronychia, and that is due to not adequate drainage of the infection. It is also due to fungal infection, which requires specific treatment. The treatment here is topical or oral antifungal agents, and that can eradicate fungal infection, but a nail bed may have to be laid open, or in other words, it has to be marsupialized. So that's a term for being laid open. And the care is also taken to avoid damaging the nail matrix. So this is the nail matrix, as you can see in this picture. So that's the treatment for paronychia. Now coming to the second infection, and that is phelon, also known as pulp infection. That is caused by a prick injury. So it is caused by a plant in the UK is known as blackthorn plant, and those people staying in the UK would get pricked by this blackthorn plant. And that's how the term blackthorn injuries, which happens in the UK. But among Malaysians, it is due to the oil palm branch. The oil from palm branch that pricks the pricks the finger, and it causes this infection. So this is among Malaysians. And the most common organism for this is Staphylococcus aureus. And the patient would complain of throbbing pain, whereby in the fingertips, it comes with the pain in the fingertips, and also it becomes swollen, red, and tender. As you can see in the picture here, it is swollen, red, and tender. And the treatment for phelon is that the condition has to be recognized early, and then if antibiotic treatment and elevation of hand, so those uh, treatment and management, those things can able to suffice the infection. And once the abscess is formed, the pus must be released through a small incision over the site of maximum tenderness. So these are the incisions to drain the abscess. So like pulp abscess, distal tendon sheath, web abscess, thenar space infection, and then extensive sheath infection. This is also another incision. These are all incisions basically. Another one is incision at the proximal tendon sheath and incision at the space of corona. So as you can see here, the infections, the the incision for draining off the abscess will avoid the palmar crease, and that is because of the underlying vessels in the at the palmar crease, and that's the reason why it has to be avoided. And if the treatment is delayed, the infection may spread to the bone, the joint or the flexor tendon sheath. So that is about the phalon. And post-operatively, the finger will be dressed with a loose packing of gauze. Okay, and antibiotic treatment will be modified if the results of the culture and sensitivity dictates the treatment. So, according to the results from the culture and sensitivity, will the treatment be modified? Antibiotic treatment will be modified based on the culture and sensitivity, and it will be continued until the all signs of infection have cleared. The wound will then gradually heal by secondary intention. So that's about phalon. Now coming to herpetic whitlow. So herpetic whitlow is basically caused by herpes simplex virus, where the herpes simplex virus will enter the fingertip. As you can see in this diagram here, this is how it enters the fingertip, and it comes through auto-inoculation from the patient's own mouth or genitalia, or cross-infection during dental surgery. Small vesicles will then be formed on the fingertip, as you can see here, and it then combines together and it ulcerates. The condition will be self-limiting, and usually it will subside after about 10 days, but it may not recur from time to time. And most important point is that herpetic whitlow should not be confused with a staphylococcal lesion. Sorry, with the staphylococcal phalon. And for the treatment of herpetic whitlow is that the surgery must not be done because it is not of help at all, and it can be even harmful if surgery is done for this condition because it would expose the finger to secondary infection. Acyclovir, which is an antiviral medicine, so this is the only treatment that can be effective in the early stages of herpetic whitlow. Now coming to the tendon sheath infection, also known as suppurative tenosynovitis. So the tendon sheath basically is a closed compartment extending from the distal palmar crease to the distal interphalangeal joint. The cause of it is Staphylococcus aureus. Again, that's the commonest organism. So as you can see here, this is the infection of it, infection of the tendon sheath. And Streptococcus and gram-negative organisms also can cause this infection. But most common is again Staphylococcus aureus. The affected digit of the finger, it will then become painful and swollen. And you have to remember the cannibal signs of flexor sheath infection. So, so the patient's affected digit, the finger basically will become painful and swollen, and then it will cause the affected hand to be held in a flexed posture of digit. A flexed posture of the finger, any finger, index finger or middle finger or ring finger. So the affected digit will be painful and swollen, and it will cause even tenderness along the course of the tendon. The pain will be the pain when the doctor uh, hold the patient's finger and flex it. Patient will still feel the pain, and even though if the patient wants to move his or her finger by themselves, also pain will occur. So that's what it mean by pain on passive finger extension, which means the doctor is helping the patient out in extending the finger, but pain on active flexion is the patient flexing the finger by his or herself, and that would cause pain in this case. So so these are the cannibal signs of flexor sheath infection. And suppose if the diagnosis is delayed, it will then result in progressive rise in pressure within the sheath. There will be also consequent risk of vascular occlusion and tendon necrosis. But in neglected cases, the infection may spread proximally within the radial or the ulnar bursa or from one to the another, and that's known as a horseshoe abscess. Also, it spreads proximally to the flexor compartment at wrist and into peroneal space in the forearm. This this peroneal space term I've already mentioned earlier, so you can look up and see. And it occasionally results in median nerve compression. So that's one thing important to note here. And for the treatment of tendon sheath infection, it would start as soon as a diagnosis is suspected. The hand will be elevated and splintered. Antibiotics would then be administered intravenously. So it's either a broad spectrum penicillin or a systemic cephalosporin. Suppose if there's no improvement after 24 hours, the surgical drainage will then be essential. Two incisions are needed, one at the proximal end of the sheath and one at the distal end of sheath. So using a fine catheter, the sheath would then be irrigated, and this irrigation must be always from the proximal side of the hand to the distal part of the hand with irrigation solution. And proximal incisions are needed if synovial bursa are infected. And once the operation is done, the hand will then be wrapped in absorbent dressings and it will be splintered in the position of safe immobilization. Dressings also should not be bulky because that would make it difficult to ensure the correct positioning of the joints. Then the flexor sheath catheter will be left in place using a syringe, and the sheath would then be irrigated with 20 ml of saline 3 or 4 times a day for the next 2 days. The catheter and dressings would then be removed and finger movements are started. So finger movements basically they are important because if not, the patient would experience stiffness and that would be a very real risk. So early supervision hand therapy must be arranged. That's also important. And now coming to the deep facial space infection, whereby the large, thenar and mid-palmar facial spaces are infected directly by penetrating injuries or secondary spread from a web space or an infected tendon sheath. So as you can see in the picture here, this is how it looks like. The clinical signs can be misleading where the hand is painful, but because of the tight, deep fascia, it may be a little or no swelling in palm, while the dorsum of the hand would bulge like an inflated glove. And the tenderness would be very extensive, and patient would even hold the hand as still as possible. The treatment is both empirical and surgical, where splintage and intravenous antibiotics they are commenced as soon as the diagnosis is made. So for the drainage part, the incision will be made directly over the abscess, being careful again not to cross the flexor creases, and sinus forceps are inserted if the web space is infected, and that too should be incised. Thenar space abscess can then be approached through the first web space, but do not incise in the line of the skin fold. Do not do an incision in the line of the skin fold or thorough separate dorsal and palmar incisions around the thenar eminence. So it can be approached in both ways. And most importantly, great care must be taken to avoid damage to the tendons, nerves, and the blood vessels. And you can see here the anatomical surgery where the deep mid-palmar space, which is here, it lies between the flexor tendons and the metacarpals. They are drained through the incision in the web space between the middle and the ring fingers. So this is the middle finger and this is the ring finger. Wider exposure through transverse or oblique palmar incision is preferable, and taking care again not to cross the flexor creases directly. As I have mentioned earlier, why incision should not cross the flexor creases, and that's because of the vessels underlying it. And do not be misled by the swelling on the back of the hand into attempting drainage through the dorsalis back. Occasionally, deep infection would extend proximally across the wrist, which causes symptoms of median nerve compression. The pus can be drained either through anteromedial or anterolateral approaches. Incisions are directly over the flexor tendons and median nerves are avoided. So in other words, incision should not be made over the flexor tendons and the median nerve because it can cause median nerve injury and all that. Operation wounds are either loosely stitched or they should be left open. Bulky dressings and saline irrigation are done, and it should be done, and it's more or less as described for tendon sheath infections. So that's all from my part, and thank you for listening to my video. If you like this video, please like, share, and subscribe to this channel. I'll be posting more videos, and thank you once again for seeing my videos. Thank you.